No.
Hi, I'm Nargis,
I'm Roxana. I'm Umi.
I'm Andy.
and we're presenting on San Antonio Medical Clinic for our organizational observation presentation. So a little bit of history about the organization. It was established in 1989. In 2000, Dr. Renee Lim took operational control. It's located in Panorama City. It serves medically disadvantaged population. And today there are 5 medical providers and 32 employees. They see around 200 to 300 patients daily, and they focus primarily on prevention. In the future, they aim to provide or to hire more specialists and expand to urgent care facilities, a surgery center, or a nursing home. The clinic is located at 14427 Chase Street in Panorama City, and it has 9 examination rooms. It also has 2 waiting room areas, and they use EMDs for their records, for their electronic medical records. And they also participate in the care immunization registry. So the staff of SNMC, they have, a little bit more knowledge about the community that they're serving. So this is just an organizational chart. Dr. Lim is at the head of it, so he's the primary physician there. He's also the founder of it. And then you have the medical providers, lab, patient coordinators, billing and referrals departments, and they're all directly under him. So the mission, vision, values, and goals are also highlighted for San Antonio Medical Clinic. The mission is to provide community-friendly, informed, affordable, quality healthcare to their patients. The vision is to be at the forefront of healthcare in San Fernando Valley. They value diversity, integrity, excellence, respect, and compassion, according to Zolisa Fernando. And their goals are to serve the disadvantaged community with quality care and to keep families healthy and safe. So their mission and vision are actually highlighted on their website. The values were not highlighted, so that's something that we asked through personal communication during our interview. The ethnic group that we're going to be focusing on that San Antonio Medical Clinic serves, or one of the main ones that they do serve, is the Filipino community, so Filipino American population. According to the LA Times City Profile, which drew upon the 2000 US Census, Panorama City has a population of over 65,000, so 65,766 residents. And then 2008 data from the LA Department of City Planning estimates that that Panorama City is at 69,630. About 5.4% of the population, or about 3,760 people, identify as Filipino. And so as part of our organization observation, we included the CAF Cultural Assessment Framework. So this provides practitioners with an assessment approach for better understanding the nuances between mainstream culture and specific ethnic groups targeted for intervention. It's a useful tool for both the clinical setting and for health promotion and disease prevention. And there's 5 major levels of assessment for CAF. There's the cultural and/or ethnic groups' specific demographic characteristics, their epidemiological and environmental influences, their cultural or ethnic group characteristics, the healthcare beliefs and practices, and then the Western Health Organization and service delivery variables. So SNMC could utilize all of these to provide better services for their Filipino American population if they wanted to. So Andy is going to discuss the demographic characteristics of this population.
Hello again, it's Andy. So the age and gender distribution of the Filipino American population, according to 2015 data, is that the median age for the Filipino Americans in the US is 49 years. And this compares to 43 years for overall US immigrant population, which means if you were to take all the immigrants in the United States, their median age would be 43. And 36 for the native-born U.S. population. So comparatively, the Filipino immigrant population is older. 76% of Filipino immigrants in the US are between the ages of 18 and 64. That's considered working age. Only about 5% are under 18, and 19% are 65 and older. So some of the cultural rules that govern behaviors related to age are there's this one term called utang na loob. I'm sorry if I'm mispronouncing it. It basically means a lifelong debt of gratitude. If your parents took care of you, you owe them, and you can never repay this debt. The next one is hiya, and that just means that you behave in a way that does not shame your family, which is common among a lot of Asian cultures, like Japan, China. China specifically has saving face as a governing rule. So according to an article by Darling et al., we saw that parents have legitimate authority, so adolescents have to obey them. This can lead to conflict, especially if the parents set rules and the adolescents abiding by their culture has to obey them, even if they're not happy with the rules. Girls have more rules that they have to follow than boys. So females, there's a lot more rules attached to females and how they should behave compared to boys. Term that can describe how they treat their families. The younger family treating their older family is called filial responsibility, which can also explain sort of a duty to take care of your family as they get older. Let's see. This data we pulled also from the Migration Policy Institute, which just shows what I had already spoken about. It's just a table that shows the data. And this one shows the population by age and sex. So one of the things that you should notice is that the female population is actually greater than the male population. The data shows that something around 60% of Filipino American immigrants are female compared to 40% of males. Okay, so the next thing is social class and status distinctions. We found a study that explains some of the reasons why Asian population groups immigrate to this country. For Filipino immigrants, the main reasons are for employment and educational opportunities. And the Filipino culture values education. So about 43% of foreign-born Filipinos have already earned their bachelor's degree, and the median income for a Filipino household is around 82,000, almost 83,000 compared to 48,000 for all immigrants, the median for all immigrants in the country, and about 53,000 for U.S.-born households. So they're very successful as an ethnic group overall. The poverty rate is actually kind of low. It's about 7% compared to the 15% for the U.S. native-born and about 19% for the overall foreign-born population. In terms of how this affects health, illness, and disease, we know that private health insurance rates among Filipino Americans is much higher than it is among immigrants overall and among U.S. native-born. So about 73% have private health insurance compared to only half for immigrants overall, and little over or about 2/3 for native-born, U.S. native-born people. Whoops, sorry about that. So distribution of formal educational attainment. So Filipino-born adults that have immigrated to the U.S. are more likely to have graduated from university compared to all other U.S.-born adults and immigrants. So 25 and older, about 48% have a bachelor's degree, compared to immigrants overall is only about 27, and U.S.-born is only about 29. And as you can see, the number who don't have any high school diploma or GED is very low. It's less than 10%, compared to about 31% of immigrants overall do not have a high school diploma or GED equivalent. And even those that don't have bachelor's degrees, about 43% of them have high school and above. compared to the foreign-born and U.S.-born. Not as great as U.S.-born, but better than foreign-born. So, based on that, we know that Filipinos as an ethnic group, they value education and educational opportunities, and it's a major reason why they come here again. In terms of language, English language proficiency, you can see that most Filipinos, more than 2/3, actually have strong U.S. English skills. What that means, or I learned that the reason why that is because in the Philippines, they actually teach English as a standard language, and English is actually the second official language of the Philippines. Only less than 1% of Filipino immigrants don't speak English at all. And 55% speak it very well. 14% only speak English. They don't speak any other language. Compare the limited English proficiency among Filipino immigrants against that of immigrants in general in the U.S., and you can see that it's a big difference. So in the Philippines, the primary language is Tagalog. It's about 29, about 30% of people speak it. English is the second language, and as with other languages, when there's two bilingualism, you sort of get a hybrid. In this case, we call it Taglish. It's kind of like Spanglish, but with Tagalog. And there's a lot of other languages in the Philippines. Cebuano, Ilocano, Ilonggo, Ware, Bicolano, Kapampangan, and Pangasinan. There's actually a few more than that, but these are the most common ones. We found data that shows that about 40% of first-gen immigrant children only speak English versus 77% of second-generation Filipino immigrant children and about 94% of third generation. So what ends up happening, this doesn't mean that they don't speak another language, it just means at home they only speak English. So as more and more third generation, fourth generation, fifth generation Filipino immigrants start to be born in the US, more of them are only going to speak English in their home. This basically just shows what I did. It actually shows a comparison with other ethnic groups in the country, including other Asian ethnic groups. So there's not much different, as you can see, with all the other cultures. It's the same trend. First, second generation. By the third generation, the majority of them only speak English. So this one is cultural and or ethnic groups, cultural and or ethnic group specific demographics. The primary religious orientation of Filipino Americans is Christian, about 65% Catholic, and 21% Protestant. There really aren't that many other significant percentage of Filipino immigrants with other religions besides Christian. So let's see. Traditional occupations for Filipino Americans, a lot of them work in the healthcare sector, but as you can see, there's service and personal care, which is a part of the healthcare sector. Then there's manufacturing, installation and repair, administrative support. Among Filipino American women, registered nurses, almost 1/5 of Filipino American women of working age are registered nurses. So healthcare is very important. It's a big industry for Filipino Americans in this country. And they're more likely to work here. Filipino Americans are more likely to work in healthcare than any other immigrants. This is just a table that shows basically more statistics about where Filipino Americans work. If you compare Filipino-born versus other foreign-born people, you start to see the percentages. As you can see, in terms of construction, even though Filipino males, about 10.7% work in construction, this compares to almost a quarter of other foreign-born immigrant males. So traditional occupations, yeah, they work mostly in the healthcare sector and the finance sector and the administrative support. As a result, the fact that these occupations are low hazard compared to something like construction work, we believe that Filipinos are mostly exposed to hazardous chemicals if they work in those dangerous working conditions, such as construction work and manufacturing and repair, but not in healthcare related businesses or industries. Whoops, let me show you this one. Okay, so the typical family size according to 1990, I know the data is outdated, it's the most recent data we could find. For Filipino, it's about 4 people in a family. But another data source that we found told us that it was more 3.1. This is a little more recent from 2000, the 2000 census. On the side here, it says 3.41. So it's not the biggest typical family for Asian Americans. The biggest one that we can see here is the Hmong community, which is another small overlooked Asian community in the country. They have about 6, and the Cambodian community have about 4.5. So Filipinos are not the largest. Okay, so sorry. Acculturation and assimilation. The immigration of Filipinos occurred in 3 major waves. The first one started in about 1899. The United States annexed the Philippines, and then Filipino students were encouraged to come to the US to study. This happened for about 3 decades. Other Filipinos who immigrated during that time, they basically just worked as agricultural laborers, which were taking jobs from Chinese laborers. Okay, the next wave of immigration for Filipino immigrants happened after World War II. Basically, the Pacific Theater of War, where U.S. Navy servicemen served during World War II, became a source of Filipino war brides. And also U.S. Navy recruits. So a lot of Filipino immigrants from during that time period became U.S. Navy recruits. And during this time is when Filipino immigrants started working and trained to work in the healthcare sector. So they took up positions like nurses, which is still common for Filipino immigrants to this day. In 1965, the third wave happened not just for Filipino immigrants, for a lot of immigrants, because the government actually loosened a quota system that was established in the American Immigration and Nationality Acts, the Immigration and Nationality Act, which sort of controlled immigration. That ended, so it led to a huge influx of Filipino immigrants. Another reason why there was a large influx during this time period was because the U.S. and the Philippines had good ties, good business ties at that point. So we were able to find distribution of the different generations of Filipino immigrants only for the first 2 generations, not for third and later on. So as of 2012, 1.67 million immigrants that lived in the country were, hold on, 1 second. So 1.76 million. That's the first generation. So about 67% of the group 67% of the group that arrived before 2000, 33% arrived after 2000, and the median age for the first generation is about 48. About 1/6 of the first generations are over 65, and more than 2/3, or actually 3/4, are between 18 and 64, which is working age. So about 1.23 million are considered second generation immigrants. About 53%, or a little more than half, have 2 Filipino immigrant parents, whereas about 38% have identified 1 parent that was born in the US. The median age for the second generation is about 20, and more than half are between working age. 42% are they're under 18, and a little 3% are already over 65. And as I said before, there's not a lot of data on the third generation. Okay, so now I'm going to turn it over to Roxana, who will talk more about the morbidity and mortality among Filipino Americans.
Hi, everyone. So a little bit more about the epidemiological and environmental influences within this population. So the leading causes of morbidity, we found that overweight and obesity are the leading causes of morbidity among Filipino Americans. Filipino Americans also have the highest rates of hypertension than any other Asian American. Some of the causes of mortality are cardiovascular disease, which is the leading cause of death. And actually a little bit more about the obesity. Over 71% of the population is actually considered overweight and obese. And hypertension is also leading cause. So cancer is the second leading cause of death among Filipino Americans. Specifically liver cancer. It's the highest among Filipino Americans than any other Asian American. And a little bit more about cancer rates. Among males, among men, prostate cancer is the most commonly diagnosed cancer. Among Filipino women, breast cancer is a leading cause. And for both Filipino men and women, colorectal cancer is a leading cause of death. And stroke is also a leading cause of death for males. Chronic respiratory disease is also a cause of death for Filipino males. And a little bit about immunization rates and levels among this population. Only about 50% of the population has received the influenza shot in the last 12 months. For individuals that are over 65, only 23 have received a shot for pneumonia. And for hepatitis B, which is the first successful immunization against cancer, and as we know, cancer is pretty predominant among this population, but the uptake of the injection among Filipinos is low, and there is about a 4% infection rate. Okay, and now I'm going to pass it over to Umi to talk about the cultural and ethnic group characteristics.
So cultural and ethnic identity, the Filipino Americans are ranked the second largest Asian group in the US with more than 1.8 million people according to the 2000 census. There are about 80 to 100 ethnic languages. Filipino Americans speak a combination of English and Tagalog, or Tagalog, which is a hybrid language spoken by many. There are an estimated 80% of Filipino who are Catholic, some are Protestant, others are Applicapi, and there are also Filipino Muslims. An estimated 80% of Filipino who are Catholic, some are Protestants. The Filipino Muslims originated from Ipinio, the Filipino Muslim originated from Ipinio, who are Catholic. Is it making sense? There was an arrow on this one. There are Filipino Muslims from Mindanao and Sulu. The time orientation. So East Asians will seek to hold on traditions that were significant in the past and a future-oriented group. It affects diseases prevention because the issue is about potential for bringing about changes and what the health promoter might need to consider when planning for health or other social changes in the target group. The perception of self. Perception of self is identified among East Asian group. The goal take precedence over those of the individuals. Asian American culture in general believe individualism is not priority and Filipinos are more collective. So young and first and second generation Filipino Americans and older adults strongly agree that children should be taught to care for elders and take care of the aging parents. Perception of the community. So a gatekeeper is a person who controls access to something. Filipino Americans will not question doctors and obtain a second opinion. And obtaining a second opinion is rarely done, and doing so would be would be an embarrassment for both parties and an insult to the wisdom of the physician, according to Singer and Co. The social norms and values and customs of the Filipino family is a unique and most able social system of care from birth to end life. Traditional Filipino American families pass on this value to new generations. The families experience acculturation factors such as nativity, psychosocial, economic stress, and the level of affinity to traditional cultures, values, which may influence the nature of quality of the support that is available. The effects of acculturation or intergenerational Filipino families contribute to heterogeneity within this population, particularly in the values, health belief, health practices, and attitude towards healthcare and social service programs. The communication patterns. There are verbal communication and nonverbal communication. So verbal includes being able to read and write, and many elderly Filipino are proud of this ability to do so. Communication is very important for a physician. And nonverbal communication, there are 6 nonverbal communication. The first one is passive communication, which is allowing a brief period of silence in order for the patients to absorb the information in their native language, so if they have a translator. The second one is physical distance, which is personal space of 1 to 2 feet. A seated position is mainly what is appropriate and recommended. The third one is eye contact, which is sit at eye level with the patient in order to make them feel more comfortable, and also not to look down on the patients because it shows like a disrespect. The fourth one is emotional response. So that is, it's observed in changes of facial expression. And the fifth one is body movement, which is such as frequent hand movement. And the last one is touching. So for example, young female providers should practice discretion with regards to touch older Filipino male patients. So many elders, particularly from intergenerational household, look to a trusted adult family member as their surrogate decision maker, and would expect the clinician to keep this individual informed issues related to their health. Such preference may not express or openly discussed by elders and family members. So now I'll give it over to Nargis.
Okay, so I'm going to be discussing general and specific healthcare beliefs and practices for this population. Some of the traditional explanations, so first we're going to look at the explanatory models for this group. Some of the traditional explanations for illness, disease, and death include the principle of balance known as timbang. And so what this is it looks at everything as having a sort of balance, and whenever the balance is whenever something is out of balance, that's when illness arises. So there's a disturbance of balance would lead to a number of health issues. They also, it might be a shift from a hot to cold. That may also lead to disease. There's also warm environments, which are essential to maintaining optimum health. And then sudden changes in weather patterns may also upset this balance. So it's a very careful balance, and anything that upsets the balance will lead to illness, according to this explanatory model. And essentially, the idea of timbang, it's a key indigenous health concept, and a lot of the ideas do revolve around hot and cold, concerning humoral balances in the body, as well as dietary balances. Like we said, hot and cold foods. Hot foods are kind of soothing, and then colder foods are to be avoided. And illness is also believed to result from mystical, personalistic, or naturalistic causes. So mystical causes are usually associated with behaviors such as retribution from ancestors or unfulfilled obligations. And some believe that in soul loss and that sleep is related to the wandering of the soul. So definitely mystical mystics or that area is believed to stem or lead to illness. And there's also personalistic. Personalistic has to do with diseases caused by social punishment or, again, retribution by supernatural beings or evil spirits. And then we also have naturalistic causes. And these naturalistic causes, they can include a range of factors from natural events or events stemming from nature, so thunder, lightning, drought, etc., excessive stress, incompatible food and drugs, infection, or familial susceptibility. So a lot of these traditional models are actually in opposition with Western explanatory models. So the hot and cold humors, they're not necessarily accepted in the biomedical model in the West. Responses to illness. So the Filipino American population, this group that we're discussing, they may use a folk medicine practitioner known as a hilot, and it can be translated as like a massage therapist, in addition to the use of like Western healthcare. So they might not necessarily stick to one or the other, so either Western biomedical model or the traditional model. They might actually use a mixture of both. So some of these traditional treatments or health promotion concepts include flushing, heating, and protecting. Flushing has to do with the body as being thought of as a vessel. And so because it's thought of as a vessel or container, it's thought to collect impurities. And these impurities have to be cleansed by stimulating physiological events such as sweating, vomiting, expelling gas, having an appropriate volume of menstrual bleeding. The next one would be heating, and that's just related to the balance described above. So like including hot foods, more kind of related to diet. And there's also protecting, and so that's more of a gatekeeping system to guard the body. Okay, and then they also believe in a syncretic belief system. So the Filipino American population may simultaneously, as was stated earlier, they may use folk medicine, so a mixture of prayer through Catholicism, and then Western medicine as well. This population will also follow their doctor's orders for the most part, as the community has a great respect for authority. As when we discussed before, they will feel embarrassed to even question their doctors. So they do have a great respect for their authority. And then Filipino American belief corresponds with the Western biomedical model in regards to consequence and treatment. And some health behavior practices. So for Santa Nina Medical Clinic specifically, the organization that we're observing, it is in Panorama City. Panorama City is a food desert, so there's a high quantity of fast food areas, which we saw when we were going on our observation. Just driving down the street, the main streets, there's a lot of fast food areas, very few areas for like fresh produce. So this might be an issue in maintaining health for the Filipino American population, especially if they're struggling with diabetes and other diseases, other health risks. Diet and reliance on cultural healers may also act to block the effectiveness of health promotion programs to achieve their objectives. So although for the most part they may use a mixture of both Western and traditional models of healthcare, if they do rely more on the traditional model and fail to see their healthcare providers, this may lead to poor health outcomes. And so during our observation checklist included a certain amount of criteria. The first one being a display of signs in Spanish, Tagalog, and English, having a properly sized waiting room, having bilingual information posters, having signs that indicate that the staff is bilingual, so patients are aware that there's somebody that they can communicate with, because sometimes it might not be so visible or clear. And then also a clear, visible mission statement or policy within the internal setting of the organization, as well as bilingual informational pamphlets. Of these 6 criteria, we actually only observed that they were able to follow 4. So they did have signs displayed in Spanish, Tagalog, and English. The exit and enter signs were in Spanish and English. They had signs pertaining to entryways in both languages, Spanish and English. They had a properly sized waiting room. So the waiting room was set up with a number of chairs in the middle and then chairs surrounding the perimeter. And there was a TV on for children because they do offer vaccination services as well. So they made sure to have those services available. And the waiting room, it was not like over capacity. You could definitely see that it was adequately sized. There were informational posters on the walls, quite a few. However, we noticed that even though the population primarily spoke either Tagalog or Spanish, all of the informational posters were in English. So to us, that kind of indicated that they needed to maybe work on getting more bilingual posters, either in Spanish and Tagalog or both. That would definitely benefit the organization. They did have signs that indicate the staff was bilingual. They did have a sign that says, "We do speak Spanish, hablo español." There was not one for Tagalog, but just having the Spanish one, we did notice that. Their mission statement and policy was actually not visible within the internal setting of the organization, but it was depicted on their website. So if you do visit Santonino's medical clinic's website, it will definitely state their mission statement, their policy, their vision, which we saw on the slides earlier, one of the first slides for this presentation. But it was not seen in the internal environment, in the internal setting. And the bilingual informational pamphlets, they were there as well. So they had pamphlets in Spanish and English. They did not have pamphlets again in Tagalog. And because a large portion of their population base does speak Tagalog, they would definitely benefit from having those there. And I'm going to give it over to Roxana, who's going to discuss the interviews.
Okay, so the first interview we did was with Solisa, and she's a physician assistant at Santo Niño. So here are some of the questions. As you can see, we asked what ethnic or cultural groups or communities does the organization serve? And she responded with the organization primarily serves a Hispanic and Filipino community. In addition to those 2 communities, they also serve low-income individuals, and oftentimes these 2 overlap. And we asked, does your organization provide culturally competency training? And they do. It's non-formal. All of their staff are bilingual and bicultural. They all speak Tagalog or Spanish, and the front staff is trained to speak to those patients in any of those languages that they're most comfortable with. The next question was, what are your organization's mission, and do you feel as though it is positively impacting the Filipino population? And she responded with, yes, the population has greatly benefited from the preventative services, as I explained earlier, and specifically with vaccinations. Many choose this because their staff is able to speak to them in Tagalog, which is obviously key in addressing these issues among the Filipino community. And so we asked how well the staff is able to abide by the organization's mission, value, and goals. And so their mission is to provide the community with the best care possible while still being affordable. Our staff is just as diverse as the community to serve, and by being familiar, they provide the best care to the patients. So the last question that we asked for the interview portion was, what are the ways in which you assess your organization's success of providing culturally competent services to the FA population as well as other populations? And currently there isn't a formal way of assessing the organization's success, but this is something that they can work on in the future. And for the second interview, Andy conducted it, so he's gonna speak about it.
Hello again. So I interviewed Dr. Renee Lim. He is the founder of the Santo Nino Medical Clinic. We asked the same questions. The first one was, what ethnic or cultural groups does the organization serve? Again, the answer was the same, primarily Filipino and Hispanic people. So the second question was, does your organization provide cultural competency training? They said there is no formal training. Whether or not that's a problem, well, depending on the population group that they primarily serve, it doesn't have to be a problem, since Dr. Renee Lim himself is Filipino, so he's pretty much intimately aware of the culture, and he's able to help people who are part of his culture. But I guess in some way, this does limit the type of people who can easily access his clinic. And the next question is, what is your organization's mission, and do you feel as though it is positively impacting the Filipino population? Well, the mission is to provide quality, affordable services to their community. Dr. Lim believes that they succeed at providing these services. The fourth question was, how well does your staff abide by the organization's mission, value, and goals? Dr. Renee Lim said that he thinks that they're doing a great job at providing services that cater to the community's needs. And he says all the staff treat the patients with kindness and respect. As far as the final question, what are the ways in which they assess their organization's success for providing culturally competent services to Filipino American population as well as other populations that the clinic serves? They don't do anything formal. They don't do major assessments. They basically just have these non-formal check-ins with each other. They talk about what's going on, and if they do have any serious meetings, it's done on an as-needed basis. If something comes up where they need to meet, they'll meet. So now I'm going to let Nargis continue and finish this PowerPoint off. Thank you.
Okay, so we also examined the way in which patients come in and go out of Santo Nino. So a relatively healthy patient comes in, they get their checkup. It definitely does help that the staff speak majority of the languages of their patient population, including Tagalog. So they provide culturally competent preventative care. The patient embraces total health, and they're able to compare and kind of improve their system as they move forward. And it definitely does help that their care is culturally competent. Again, it's not formally, they're not formally trained on it, but the fact that they have the bilingual signs, the pamphlets, you can definitely see that they're catering to their patient population. And then we also conducted a SWOT analysis. So we focused on the strengths, weaknesses, opportunities, and threats that we observed from this organization. Some of the strengths, just to highlight some, the organization, definitely medical personnel within the organization are able to speak multiple languages, so they did not need interpreters at all. The weaknesses, though, they rely on income from the low-income community, lack of patient communication, training for staff. That was definitely one of the weaknesses, lack of formal training. Some of the opportunities include providing, again, formal cultural competency training to their staff. And then some of the threats, again, include unhealthy external environments, so food desert, high pollution, and then also the unstable economics of the region could adversely affect the organization. So the current issues with Medicaid and the current political environment currently, it might affect the amount of patients that they have, because a lot of their patients are Medicaid recipients, Medi-Cal. And then during our interview with Dr. Lim, we actually had him fill out a self-assessment as well to see how he perceived the organization. So according to him, there are many roles in the organization. He also believed that everybody has separate tasks, so it's not that the tasks are not necessarily overlapping. Front desk staff do their front desk duties, medical staff do their medical duties. But he believed that the hierarchy, there was a good level of hierarchy, so he gave it a 6. For technology, he gave it an 8, and we did see that there was a good amount of electronic records and systems during our observation. The culture, he gave SNMC a 10 for high professional training. During our organization and our observation, our interview, we actually saw that there was not that high of a level of training. And he also gave the organization a 9 for having the goals well defined, and the goals were well defined on the website, but again, they weren't necessarily depicted anywhere within the internal setting of the organization. And then for culturally competent care, he gave the organization a 9, which we would agree with as well, because for the most part, rather aside from the lack of bilingual informational posters and formal training, the staff were very culturally competent and able to communicate effectively and respectfully with the patient population. And then some other recommendations that we had, I mean, we've mentioned again, adding multilingual informational posters to the waiting area to create a more inclusive, welcoming, and culturally appropriate environment for the population, specifically for the Filipino population, the Tagalog-speaking population, because there was a lot of great information for preventative health in English and Spanish, but none in Tagalog. And then also communication training to allow staff to properly interact with patients in a warm, respectful manner. And this is just to include more linguistic training, more culturally competent training. Okay. Thank you.